All right, I'm going to go ahead and get started. I didn't record the first part, but I will record this section because we're getting into some dense material. I'll go 350 miles an hour. So if you have questions, I want you to ask me. This section of pharmacology will be this week and next week. So it's basically the same slide, except that I think next week I'm going to bring in the liver slides a little bit more. We'll go a little deeper into the liver. This is where we begin talking about what happens in our bodies when we take the drug in, and what does our body do to the drug. And so there are a variety of words that we have to take a look at. And these are things that we will use all the way through. So all the way through the semester, we'll talk about the pharmacology. We'll talk about, okay, what are the pharmacodynamics here? What pharmacokinetics might we be talking about? What's the half-life? So these are terminologies that are ones that need to be part of your thinking and your vocabulary as we are talking about the different drugs. So I just put this up here. This is in the book. And by the way, the book is a good practical book. And it's a good, I picked this because I trust Dr. Preston and Dr. O'Neill. I don't know the other two, although I've seen several things by Dr. Moore. But part of it is this back cover is just a quick look at what are the meds, what are these names, and all of the meds have a generic name, which is often just hard to pronounce. And then they have a brand name. And prescribers talk about one or the other. Like, for instance, some you will hear people use imipramine, and I use imipramine, and then I always wonder what tofranil is. But other people use tofranil all the time. And the same with every medication. So having something like this available to you so that you can just open it up and say, oh, that's what that is. Yeah, well, I call it 10X. And because there's no real good way to understand what medication is other than, and to memorize all the brand names and all the generic names are just hard. Also, as you go through, so I'm on page 60 and 61, he just has these charts that can be very helpful. So 60 is a chart on the specific receptor actions. Now, if you have the 8th edition, that's fine. This has a little bit of update, and they do a better job with child and adolescent. Last year, with the 8th edition, I had people get the child and adolescent paperback, but now this one really, they did a better job with that. So it is a good practical book to have and take with you, as well as getting Hippocrates on your phone. So when we look at this definition of drug, any substance that brings about a change in biologic function through its chemical action, that includes all of our food. So we have meals of drugs. And we don't call them drugs. I haven't ever called broccoli a drug. But I rarely call broccoli, but But it's important to understand that drugs are really a broad category that have several elements that change our internal environment. So here are the two words: pharmacodynamics and pharmacokinetics, and we're going to go through them. But the pharmacodynamics and the pharmacokinetics are going to play an integral part in every medication that we'll talk about. And this is what makes prescribing medications more of an art than a precise science. Because every person, because of their unique chemical makeup and their unique internal environment, will be unique. Now, one of the things that we can use is that pharmacodynamics and pharmacokinetics tend to, and how we manage those, tend to be part of our inherited enzymes and our inherited metabolism. And so when family members have done well on a certain family of medication, usually that's a good place to start with your current patient. So we want to know if anybody in their family, particularly their immediate family, has done well or done poorly on certain kinds of drugs. So we will talk about both of these, and this we'll learn this. These are the four methods of process for pharmacokinetics, and so we'll look at those later. But this is always happening within our system. So when we look at pharmacodynamics, basically what we're looking at is that the dynamics have to do with how the drug is going to affect the body. So we take this drug, and again, remember that can be the food that you eat, as well as the medication that you're taking, the vitamins that you took, the minerals that you ingested, and we are going to look at what they do to the human body. And what they do has to do with how they're going to, binding is how they connect, and how they connect to particularly postsynaptic receptors as a chemical, but also binding needs to occur for some of these chemicals to be able to travel to the right place. So a lot of what we're looking at with medication is postsynaptic receptor activity. So that's the pharmacodynamics that we're interested in. But some of the medications actually work on the presynaptic membrane. And so we're interested in how the pharmacodynamics of the presynaptic. So the presynaptic is the part of the neuron that is synthesizing, finishing the synthesis of a neurotransmitter and releasing the neurotransmitter into the synaptic cleft. And so if the action of this drug, the pharmacodynamic action of this drug, is to change the axon button or terminal and how it reacts to the environment, then that's the receptor binding. Okay, post-receptor effects. Now, anytime, so pre is dealing with reuptake, presynaptic receptors are dealing with some of the modulation effects of the release of a neurotransmitter. Some of the presynaptic are binding with the synaptic vesicles for release of the neurotransmitter. But post is the message that goes to the next neuron so that it can move forward with what it's supposed to do. And so that has to do with an excitatory, an EPSP message, or like a dopamine will say, hold on, because it's an inhibitory message. And so postsynaptic effects can cause things to happen or keep things from happening. And we have medications that do different. And then chemical interactions with the broader environment or the internal environment. So I just have some pictures here that kind of show you some of the types of interactions that can be the drug on the body. And you know that we have fast reactions, and those are certain kinds of chemical gated receptors. And then we have slower reactions, and this isn't the picture that I like, but with a slower reaction, those tend to be ligand postsynaptic receptors, and those take longer for the neurotransmitter to get into the postsynaptic neuron to lead to its effect. This is how we can coordinate. So why does it take so long for a medication to be at a therapeutic level? And there are several reasons. One is that we usually start at a low dose because we get the side effects first. The reason we get the side effects first is that there are dopaminergic, acetylcholinergic, serotonergic receptors all over our body. Serotonin has more receptors in the gut than in the brain. And because of the way we metabolize the serotonergic medication, it goes to the gut first. So we get stomach aches, we'll get irritated bowel, we'll get constipated, or we'll have diarrhea. Those things happen first. And then it finally gets to the brain and does the things. So we start low so that the body can get used to it, and the body always wants to be in homeostasis. And so for the body to get used to the drug, we need to give it a little bit of time. And then once it's had a few days to say, whoa, what's happening? And then it has a pharmacokinetic response. Then we can up the dose. And now we've changed the pharmacodynamics, and the body is going to have to adjust again. Okay, so still with pharmacodynamics, the pharmacodynamics are affected also by the environment it's going into. So there are certain kinds of diseases, mental health issues that are a cause of genetic mutations. So something has happened in the process of proliferation, where there has been either a codon that dropped off, or there has been insertion that is in the wrong place as the chromosomes are building, as the RNA are wrapping. And so now the pharmacodynamics for that person will be different because of their own body environment. Malnutrition. Malnutrition has a couple of things. One is our neurons need sodium, potassium, calcium, and other things, but those are some of the critical ones for neuron function, and water. So when we're malnourished, we don't get the precursor for our neurons to function. We don't get the precursor for our neurons to be able to synthesize the neurotransmitter. And if we're dehydrated, then we don't have the water balance that our neurons need in order for the axon walls to be as permeable as they need to be. So then when we have the sodium potassium pump without proper water, it's not going to function well. So with dehydration, your body slows down because it doesn't have everything that it needs to function. And so then you put this drug in there, and it's going to interact with, it's kind of like we can put gas in a car, but if our spark plugs are dirty, it's not necessarily going to run well, even though it has gas. And I don't know where I came up with that, because I know so little about cars. But Parkinson's disease is dopaminergic. And so in Parkinson's disease, the dopaminergic rich area called the substantia nigra begins to the neurons begin to atrophy. And when that happens, there's less dopamine. So with less dopamine, you get problems with depression. Those usually come first. Then you get problems with thought process, and then you get problems with executive functioning, and then you begin to get the tremors and some of the other things that come with Parkinson's. So when you have a certain neurotransmitter where there is atrophy of the synthesizing neurons, the pharmacodynamics of having the drug come in will be quite different than what we expect. Now, one of the primary initial drugs that we use for Parkinson's is levodopa. Levodopa is one of the precursors for synthesizing dopamine, but you still have broken neurotransmitters for synthesizing, so it has to build the dopamine, synthesize the dopamine in other places. Getting old changes our body. Just deal with it, it happens. And so then when we are working with older adults, the mantra that we were taught is as people age, start low, go slow. And part of that is we've got to see how they're, even if they did well on this medication earlier in their life, now that they're older, and older really means 65 and older, now their body is going to change just because of the aging process. And so it's important to really see what the side effects are going to be. Now in this country, for older people, we tuck them away and we give them lots of drugs because we just are a little bit messed up in our way of thinking. Okay, that was a bias of my own, okay? But I have worked with so many older adults where the first thing I did was to look at their med list and say, we need to get rid of that. We don't need this, we don't need this, we don't need this, because we just tend to lock on drugs. We do this with kids in the foster care system as well. We do this with marginalized patients. They come in, they have a problem, we make assumptions and we just lock on drugs. And as we have become more specialized, so you go to this person for this, you go to this person, they don't look at what other medications are being prescribed. And if the person doesn't remember or they aren't asked, now you are going to lock on a drug that may have a dynamic interaction with this body, with its environment, with this other drugs that sometimes can be fatal. So that's one of the things that even if you don't go on for a degree, and most of you won't, because most psychologists don't want to be prescribing psychologists, and that's fine. But understanding as you're working with your patients that it's important to pay attention to what this drug is going to do with their body, given the various kinds of things that can happen in terms of their own chromosomes and what other drugs are present, is critical for us to take a look at. I will show you as we go through how to look at drug-drug interactions and drug-food interactions and drug-herb interactions. And that's something you can do without prescribing privileges. And that's important for us to do. People with medical complex situations will be given medications that are important for them that cause mental health issues. And so now what we are doing is that we are thinking through what are the pharmacodynamics of this drug on this person with these drugs, and can we alleviate any of them? That's the reason for the second assignment. And some of you will find cases where you have people who maybe are on 8 to 15 medications. And I challenge you in a nice way to go through and really examine those, because some of them they don't need. And yet their prescribers just haven't looked at what they're on. Okay, pharmacokinetics. This is how your body is going to affect the drug. So your body is not passive. So the drug comes in, and we intend for the drug to have this impact on the body. We want the good part of the drug, what it's supposed to do, but we know that there are bad parts. And so it's going to affect us, but also our body is going to be active with this drug, and that's the pharmacokinetics. And these also can be changing. So how the body affects is it determines the onset. When is your body going to start working with this drug? And it depends on how it is administered. So we have different ways of administering drugs. The most common is a pill form, but that's not necessarily the most effective. And then the duration. How long is your body going to keep this drug in its system in an active phase? And then what's the intensity? And this has to do with particularly liver function, and for some of them, your kidney functions or renal functions. And we have to understand that not everybody will have the same response, even within biological families, because every person is, in fact, their unique environment. Now, there may be commonalities, and we use those to the best that we can, but it's important for us to understand what is the body going to do that will affect this drug. So pharmacodynamics, what the drug does to the body; pharmacokinetics, what the body is going to do to the drug. I just say it here, I say it a lot. So if we look at this, we can see all of the bidirectional relationships. So this, if you think of this as the body, so the drug is coming from the outside and it is going to go into the body, and it will affect doses and concentrations. We will increase, decrease. We will change how their lifestyle. We might ask them to change their diet. I told BioFoundations, grapefruit is the most pharmacokinetic food that we have. Actually, it's pharmacodynamics of grapefruit, but grapefruit interacts with a lot of our psychopharm medications. And so there are many of them. And grapefruit juice will win. So when the medication that we're giving the person for a mental health reason goes to the liver, and they have grapefruit for breakfast and that goes to the liver, the grapefruit will win. And then the medication will be less than or ineffective. So charbroiled foods is another one that interacts and can decrease. And birth control pills interact with some of our meds, so that, but the meds kind of win over the birth control. So now a woman is on, and this is oral birth control, and they're taking a medication and they don't want to get pregnant, but the medication, unbeknownst to them, is decreasing the effectiveness of their birth control. And now they got pregnant on a medication that could be harmful to the fetus. And so now we're those are things that we talk to people about. And there have been so many times when I've asked a person, they said, oh yeah, I'm on a new medication. So what did your prescriber tell you about this medication? Nothing, just that I need to take it every day. And that irritates me. I think it's unethical, but that's where we come in and say, well, let me tell you a little bit about this. And we want to think through this, and we want it to do the best for you. But this is what I want you to know. And we help with the education, and we pay attention to what their body is telling them and what they are sharing with us. Okay, here's the ADBE. Okay, so this is pharmacokinetics. So how is the body going to absorb the drug? How is it going to take it in? What is it? How is the body going to react? And we'll look at the different types of application that we do in a moment. Then how is the body going to distribute, or how is it going to release the drug? And many of our medications come with isomers, and there are active isomers and inactive isomers. And part of the task is that our body needs to break them apart, because when they're together, the drug isn't effective. And during the biotransformation, the body is going to split apart. So the active isomer is taken to the receptors, and the inactive isomer is eliminated through waste. Biotransformation is important. What does the body do to the drug? What is it? Is it going to carry it? Is it going to bind with it? Is it going to just ignore it? What is the body going to do in biotransformation? And then excretion is important. So there's only one neurotransmitter that we can get levels from, and that is serotonin, and we can get levels from serum or blood or urine, but it doesn't tell us other than whether or not the person is metabolizing, but not necessarily the other effects of the drug. Yes?
Is biotransformation the same as metabolism?
It's metabolism is part of biotransformation. Yeah. Okay. Any other questions?
I forgot what's the A?
Absorption. Okay, I know this is a boatload of information and I know I'm going fast. I do not, I won't get upset if you ask questions or say, I have no idea. Or if you say, Alicia has no idea what you're talking about, would you please explain it again? I was just picking on Alicia because she's here.
Dr. Andrews?
I hear that.
It's Elizabeth. I was just wondering, what is the standard practice that prescribers are measuring the absorption, the distribution in with the body? Is this all through blood work?
No, they might do with certain medications. They'll get some labs, and then basically they say come back in a month. And the person comes back in a month, how are you feeling? Oh, I'm a little bit better. Okay, let's just keep what we're doing.
So it kind of sounds like through observation, it's speculation rather than a definitive understanding of what's happening.
Yes, absolutely. Kristen, I saw you. You have an idea.
What?
You were responding to Elizabeth, I thought.
I was just agreeing with you that there is no actual like standard protocol of measuring how this works, that this is just like, okay, you're coming in and you look great, continue on. It's not set in stone like you had said at the beginning. There's no science to it. It's more of an art.
So Elizabeth, this is why we are important, because we will know more and listen more and spend more time with our patients. Even in primary care, we will, if we have opportunity. So obviously if it's a one-time warm handoff, and yet even with a warm handoff, we're getting different information than what the prescriber may have had. And by the way, when I call the psychiatrists on the mental health task force prescribers, they hate it. I'm not exactly sure why, but prescribers is anybody who is legally prescribing the drug, and because it can be so many different people, that's what I choose to use. But when we're working with people in any of our areas, whether it's assessment or whether it's in weekly therapy or warm handoffs that maybe you're getting a 20-minute session with them every other week or every month, we know how to listen and we can ask the questions, because there is no precise way to know how their body's responding. But you ask things about, have you been constipated? Have you had stomach pains? Have you, is your mouth dry? Are you having blurry vision? Are you having ringing in your ears? But you don't have to ask those specifically, but how are you feeling? And then I'm listening. And then I'll dig a little bit deeper for the things that I know can be side effects or how their body is responding. And if they've been on the medication for 3 weeks and they don't feel anything, I ask, are you going up on your doses as you're supposed to? And I say, okay, well, this one, it sounds like for you, it's going to take 6 weeks. And you and I talked about this, that to get to a therapeutic dose. So let's keep going. Let's keep working with this. All right, this is overwhelming, but you have the some charts in the book, plus this is helpful, and this is on the PowerPoint. So you notice We have absorption, distribution, elimination. We don't have biotransformation on this chart. And so this is what you're looking for. So we're looking for bioavailability, and bioavailability has to do with how the body is taking this drug and working it, and where it is sending it to get it in a form where then it can be either bound or unbound. And so a bound portion, isomer of the drug, is going to travel. An unbound still has the ability, we call it a free drug, it still has the ability now to affect wherever it travels. And so we can't measure a free drug, and we can't see traveling drugs, but we can see the effects. So if there's too much free drug, the person will have side effects that are uncomfortable, because this drug is going around, and when there's a lot of free drug, it's going around and finding places to bind and then affecting those. And so you might go back on, you might look at what they're eating with this, but you might also go back on their dose to see if you can get some of maybe the confusion, the foggy thinking, things that they're not liking to decrease. Here is just the definition, so the very right, the under formula is the definition of what is happening. Elimination is important because we need to get rid of the part of the drug that we don't need, the filler and things like that. Also, we need to understand with clearance, this gives us an idea of whether or not our systems that are involved in getting rid of what we don't need are working. And so every neurotransmitter has a byproduct, every drug has a byproduct, and the body needs to be able to get rid of those. And so we look at clearance. Am I hearing
Dr. Andrews?
Yeah.
Yeah, I was just curious. I think it might be important if we go over why, if fillers are important, just quickly.
So, and we will do that also, but let me, so when you have particularly a capsule or a pill, it's not all the medication. It's the active isomer or the chemical, plus they pack it in substance. And in capsules, that substance can be a variety of things. And I mentioned weeds, but it is supposed to be a neutral piece of matter that is in there. And then you've got the coating of the pill or the coating of the capsule. And so when we swallow those, our body has to start digesting. So for instance, several of our medications are XR. One of the first ones was Ritalin, and Ritalin XR, all that meant was that the amount of Ritalin that they would normally take in a pill was now in a formula with a coating that took the acid in the stomach a little bit longer to break through to dissolve. And so it took longer for the drug. Concerta is just Ritalin in a formula with a coating that takes the body longer to release it. So it's still the same drug, but they can use the different kinds of coating to change the pharmacokinetics of the breakdown of the coating so that the drug is released in smaller doses over periods of time. Okay, is that enough for right now? And then we'll touch it.
Yeah. Thank you.
Okay, this is overwhelming again. And part of it is just to give you kind of a taste. So here's the person and all of their chromosomes and everything they've inherited and how their body is creating, synthesizing neurotransmitter. And then out here are all the things that can happen to change their internal environment. So diazepam is, all of the PAMs are medications that that we use really to, they're, what am I trying to say? Anxiolytics.
Anxiolytics.
Thank you. Sometimes it just doesn't come. And so it is metabolized in the liver. Desmethyldiazepam is what it becomes as the enzymes in the, we'll learn the cytochrome P450 system, enzymes break it down. So methyldiazepam is active, so it's going to now have a pharmacodynamic, and then when it is finished, it will be excreted by the kidneys. So desmethyldiazepam is going to go in, and first it's going to be in the stomach, and the stomach will begin to dissolve it, and then it's going to go to the liver, where the cytochrome P450 enzymes will break it apart, and then immediately the inactive part will be excreted. The active part will actually then circulate to the brain, do what we're hoping it will do, and then eventually is excreted through the kidneys, and all the time is affecting the different parts of the body that, so the pharmacodynamics is what the desmethyldiazepam is doing, and then the pharmacokinetics are what this person and their environment is doing. So here's stress. Stress causes us to have higher levels of cortisol, which affects our adrenal system, which affects a lot of the way our brain functions. So when stress is too high, it changes your genetic constitution. It changes the pharmacokinetics, so that now you've got this unexpected interplay of the pharmacodynamics of the drug with the pharmacokinetics of this person with stress. We'll talk about albumin, all the functions later as we go along. You can just see all the things. And so that's part of what we do in therapy. We just don't give them things that they can do to try. We listen to their whole story, so that as we're working with them, we're thinking about, okay, what is happening? What is happening with this person? Not only as they go through their life and interact with their own external environment, but how their own physiological environment might be interacting to lead to the struggles that they're having with their mental health.
Dr. Andrews, I have a quick question.
Yeah.
You've mentioned a couple times now starvation. I'm curious, I have a number of clients, young adolescent girls who have very disordered eating. Is that have implication, or is it true starvation? Can you kind of clarify?
No, anorexia in particular is one of the most deadly mental health issues we have because of what it does with potassium. So when you are malnourished, or when you have disordered eating in the form of not eating enough calories or energy for your body, then the potassium is not able to interplay in the way that it used to in the neurons, but particularly in the heart. And low levels of potassium chronically can lead to cardiac arrest. So I always take eating disorders very seriously, because they are changing the internal environment of the body, and therefore their pharmacokinetics are, first off, they're not going to function well. And so we may give them medications to help maybe with emotional regulation, or who knows what we might find them on. But they've got a body that's not going to respond in a way that we can predict. And we can, they can just die from their potassium imbalance. But
Thank
we
you.
need to talk to somebody else, something else before we go, because that was really depressing. But it was a good question. And these are things we need to think about. So here's absorption. So this is the first part of pharmacokinetics. And it has several routes. And so I just have this diagram here with a bunch of words. Lipophilicity. I usually don't, I say lipophilic, but lipophilicity is a chemical that likes fat. And those are, we have a lot of our medications for mental health that are lipophilic. And what that means is that they combine with the fat molecules, and that's part of the way they survive. Now, here are some other things. We learned ages ago, before you were even born, most of you, that THC, marijuana, the hallucinogenic part of marijuana, binds, is lipophilic. And it binds with fat cells, and it just stays there, and it loves it. And so we would...
Dr. Andrews,
yeah.
never mind.
Are you sure?
Never mind. Yes.
So I was working at the Denver VA in the PTSD unit, and we would bring in these men, and we worked solely with men in this program for 6 weeks of inpatient treatment for trauma. And it was a holistic program, and we had an enthusiastic psychiatrist as our chief. And so he would start them on military style exercise regimen. Well, they had to have a UA every Monday, and we would get it, and it was no tolerance. So if they had a dirty UA, they were out of the program. Well, we had one person who we knew because he was on suicide watch, had not had visitors, and he had a dirty UA. And so we went looking for the literature, found one article at that point that indicated that because THC is lipophilic, it can stay in the fat cells and for years. And so this was like 20, 25 years after he said he had used marijuana. And by going through the exercise and using some of his own fat cells and breaking them apart, the THC was actually re-entering his system, and that is what caused his dirty UA. So we changed our policy, and if we knew they had used, they were out. But if they just had a dirty UA, particularly for marijuana, we didn't exit them from the program, because it could just be that they were using up their fat cells. So as you have patients who are getting into lifestyle changes with good exercise, be aware of things that they have done in their past that are hiding in their fat cells that will be expressed once they start using and breaking down those fat cells. Now, I don't know if that is a more uplifting thing to end on, but we're out of time for today.
I think it's worth noting too for patients to know, and maybe us to know, that CBD, the non-psychoactive component of marijuana, will show up on a tox screen, even though it's not the psychoactive component. So people who use CBD for pain and things like that, that will show up on a drug test. And so sometimes patients who are like, I've never smoked weed, but I take CBD, like that's probably why.
Or edibles, or
right.
The oils, or you're using the creams.
Any sort of delivery system with CBD in it will show up on your tox screen.
Is that also, sorry, Dr. Andrews, does that also happen with CBD that comes from orange? I don't think so, but I just wanted to double check, because there's two different kinds of CBD. One that comes from the marijuana plant, and then one from some kind of orange.
Can you, I want to know more about the orange one. I've never heard of that one, but.
Yeah, it's less effective. I hear about it in the epilepsy clinic all the time. I get questions from patients. And so, yeah, the CBD from marijuana plant shows up on a drug support, but I don't know if the orange CBD oil does.
If it's got the same components, like molecularly, it might, right?
Yeah, and if it's lipophilic.
Right.
So that would be a good thing to take a look at. So here's a thing that Dr. Keelan warned students going to internship about way last September. And that is, even if you live in a state where it's legal to use THC and CBD, if you're going to a state where it is not and you are given a tox screen, you need to be careful about your use in whatever form, because your UA will come out dirty for THC or CBD.
Does CBD metabolize? CBD doesn't metabolize the same as THC, though, right? Like if we're exercising, can I metabolize?
Yeah, it does. It's lipophilic, yes.
Oh no.
So stop it.
Okay.
Okay.
The CBD kombucha thing, and person told me she's like, careful.
Yeah, yeah.
Oh no.
Okay, all right. Well, have a good week and have a good weekend, and I will see you next Friday. And you have a lot of things to mull around.
Dr. Andrews, is this slideshow available on Foxtail?
Well, I thought I put it there. Now I'm so
It is. I checked. It's on there.
Okay.
it's
Because I was trying to do the activity thing and I knew that I was having a hard time finding some of the answers, so I didn't know if this was available or not.
this is called pharmacology.
Pharmacology I.
Yeah,
It's right below the background activity.
it's right below the background activity. Now, so this is 510 and biobasis is 509, and I am getting them merged. So these are good questions to continue to ask me. I am trying, but sometimes the computer wins. So yeah,
I think it's all right. It's the same one.
all right, great. Okay, have a good weekend.
You too.
Thank you.
Dr. Andrews.
Yes,
Thank you.
okay, we'll see you.
I feel the need to wait.
Thank you.